So this is Nurse Practitioner Board Certification Review courses. So we'll be talking about mental health, and I will be your presenter. You can just call me Favor or Famous Favor. So we'll be going through classes of medication because you have to understand the classes of medication. To be honest, the medication in mental health is not that too broad. It's just that you need to know how to narrow it down. So the first class of medication we'll be talking about is antidepressants. Okay. So one thing about the antidepressant is broken down. This is the all the antidepressants. It starts the older ones are the TCAs and MOAs. That is the older or oldest antidepressant. But because it has a lot of side effects, which we are still going to see, then it's not the best choice. You have to use other ones before you use it. So the one that we use more common now is the SSRI. So this is just a breakdown of your antidepressants, which is SSRI, SNRI, NDRI, TCA, MAO, atypical antidepressants, and then, of course, the newer agents, which I'm not sure if they will ask in the exam, but I like to update my informations. So, but for the purpose of the exam, you must know your SSRI, SNRI, NDRI, TCA, and MAOs and the atypical. Okay, so we will be starting with SSRI. So, what is SSRI? Selective serotonin reuptake inhibitor. So, this is SSRI. And if you remember my slide, because I'm combining both of them, we say that SSRI is the first line of treatment for the six major conditions, which is depression, anxiety, OCD. We have a panic attack there too. Panic attack. We also have the generalized anxiety disorder. So this is always then we have our anorexia nervosa. This is the first thing you must know for SSRI because they can ask you in the exam, a patient have depression, a patient have generalized anxiety. Okay, so I'm going to leave this as generalized anxiety, not just anxiety. So patient have OCD, patient have panic attack, patient have generalized anxiety, anorexia nervosa, and they ask you what is the first line of treatment. Let me tell you, if you can grasp this little secret, you're already getting there. So any of these conditions that we mentioned here, SSRI is the best to use. Even a patient that have cancer, let's say they tell you patient have cancer and patient have depression, you still see that SSRI is the best choice. For elderly people, SSRI. For younger people, adolescent, SSRI. So SSRI is like the number one go to. Okay, but we'll still see all of this. But first of all, know that the first is the selective serotonin reuptake inhibitor. So what does this medication do? They increases the serotonin level in the brain. Nobody's going to be asking you this, but it's just to know how it works by blocking its reuptake at the synaptic cleft. This leads to improved mood regulation, anxiety reduction, and enhanced emotional stability over time. So, what do you need to know? You need to know the examples of SSRI. There is no other way to know this medication than to learn it, than to learn it, because there's no other way. Just find a way to learn because it's very important. Okay, it's very, very important. So, what another thing to remember is the side effects. What are the side effects of SSRI? The number one thing here is sexual dysfunction, which you know as erectile dysfunction. And the one that is highest at a sexual dysfunction is your Paxil. Paxil is the number one for sexual dysfunction. Another side effect is going to be nausea and vomiting and anxiety. Okay, we say that we use it to treat anxiety, generalized anxiety. But then you should also know that for elderly patients, there is still possibility that they may have the paradoxical effect. In mental health, whenever you hear paradoxical effect, what does that mean? It means you are giving this patient this medication to do this, but instead of it to do that, is doing the opposite of what you want it to do. So we said that we use SSRI for generalized anxiety, but it's still possible that it can still cause anxiety. It's still possible that it can still cause anxiety or increase anxiety. There may be a question, a patient is on any of these SSRI, and what are the signs and symptoms to monitor for this elderly patient? The answer can be anxiety. Okay, but know your SSRI. Find a way to learn it. The way I easily learned mine is just to use at least like secondary sec. So S is sertraline, Zoloft. E is estalopram. C is citalopram. At least for sure, I know those three. Sec. And after I know those three, I come again and I know the the P, the double P. What are the double P? The first P is paraxetin. So that paraxetin, which is the Paxil, Paxil is the one that have the shortest half life. Initially, Paxil was the number one or the first line treatment of all the SSRI, but not anymore because now they realize that Paxil is causing more erectile dysfunction, and because it's causing more erectile dysfunction, many people, the elderly people, especially the male, they don't want to take it. And Paxil is, it has the shortest half life, but then it has more anticholinergic effect. So now it's always safer to choose options like estalopram, citalopram. So it's very, and also sertraline. So that is why I called it the sec, because the sec is more commonly used, even though they have a longer half life. Then another one that have the longest half life, which is P, Prozac, Prozac P. I also remember the name as Prozac, Prolong, and I remember it as Fluzatin. So flu, when somebody have a Fluzatin, it always take like 7 days for the flu, for the person to come out of the flu. The same way, Prozac have like almost like 7 days half life. So I always remember that Prozac, Fluzatin. Then we have the sertraline, Zoloft, estalopram, Lexapro, Paraxetin, Paxil, and citalopram. There is other SSRI, but for the purpose of the exam, at least these five here, you must know. But there are other ones. So, but know this SSRI, know this medication. In fact, I have spent a lot of time trying to memorize them, remember them. So you have to do the same. But SSRI is the number one go for depression, OCD, panic attack, GAD, anorexia nervosa. So that is your SSRI. Then we have another one we call SNRI. So with this one now, it's kind of a little bit different from SSRI. SSRI is selective serotonin, so it's dealing more with serotonin. But this one is dealing with serotonin and norepinephrine. So that means it boosts both the serotonin and the epinephrine. Okay, so that means it has two function, and that is why we use this one for people that have generalized anxiety, depression, panic, the same thing we mentioned, but they also have chronic pain. So when somebody have chronic pain condition, or fibromyalgia, or diabetic neuropathy, anything that has to do with pain. Okay, so how do I remember this? I just remember this N as neuropathic pain. I'm not saying it's neuropathic pain, but that is how I remember. It's not epinephrine. But how do I remember it? Like if they said, which class of antidepressant do we give for neuropathic pain? I remember it's SNRI because I use the N in the middle to remember neuropathic pain. And another way you can remember is that I said is doing two things. It's not just the serotonin. The serotonin does the five things or the six things we mentioned. It's not just the serotonin, it's also dealing with the norepinephrine. So, what is that telling you? There is a possibility for chances of what? Increased blood pressure. We know what is norepinephrine. It's always the adrenaline, not adrenaline. It's always released during fight and flight. We learned all these things in nursing. So it's always released during what? Fight and flight. So there's possibility that it can raise the blood pressure. Unlike this first one. This first one, which is SSRI, it doesn't have anything to do with the blood pressure. But now, anytime you hear serotonin nor epinephrine, there is possibility of the blood pressure to be increased. So you have to monitor the blood pressure. And also, another way I remember it, not just any as in neuropathic pain, I also remember it as duloxetine. So, one of the medication there that is high is what? Duloxetine. So, what is duloxetine? Dual. Dual, like a dual action. Dual action, because this is the medication that is always high yield. A patient is on duloxetine, a patient is on Cymbalta. Which class of antidepressant is that? I remember dual things. It does two things. Dual Cymbalta, which is the serotonin and norepinephrine. And another medications that are there, venlafaxine, which is the Effexor, okay, and the another one is the disvalence vaccine. So, but like I said, for the purpose of the exam, Cymbalta is high yield in the exam, and Effexor is high yield, but Doloxatine is really high yield. So you can remember it using N in the middle as neuropathic pain. That is how I remember. But you can find a way to remember your own. And we said we use it to treat chronic pain, like not just depression. So when a patient have depression or generalized anxiety or panic disorder or social anxiety, and these patients still have diabetic neuropathy or chronic pain or fibromyalgia, which one will you use? That is your SNRI. And you have to monitor the symptoms of increased blood pressure. They have sexual dysfunction, but the sexual dysfunction here is less to compare with SSRI. SSRI have more sexual dysfunction. Then another class is NDRI, another class of antidepressants. Okay, this one is norepinephrine. So we are seeing that epinephrine again. Norepinephrine, dopamine reuptake. So this is one is also two things. So it's working to inhibit both the norepinephrine and the dopamine. So which one is this one? That is your Wellbutrin. Very high yield in the exam. So when a patient is on SSRI and patient is having erectile dysfunction, what medication do we give them? Wellbutrin is very high yield in the exam because Wellbutrin is an NDRI. And NDRI, they have less chances of sexual dysfunction. So because they have less chances of sexual dysfunction, it's more better to use for somebody that has a erectile dysfunction or that doesn't want the one that will cause them. So where you will see NDRI use more is if a patient is worried of erectile dysfunction. Okay, but another thing you need to remember about this Wellbutrin, it's kind of so confusing. It is under three names. What are three names? Bupropion. You may be hearing bupropion. Bupropion is also known as Wellbutrin. And you also may be hearing it as Ziban. Ziban is also Wellbutrin, but this is how it is prescribed when you are talking about smoking cessation. All this thing is high yield in the exam. So let's say they ask you a question, patient, you want to prescribe something or recommend something for smoking cessation, what class of medication do you recommend? That is NDRI. And what is the example of the medication there? That is Ziban. So I can still say Wellbutrin, the class of medication is bupropion, but it can be dispensed as Wellbutrin. Then if the person needs something for smoking cessation, it can be dispensed as Ziban, but they are still the same norepinephrine dopamine reuptake inhibitor. You need to be understanding the classification of medication because that is how you'll be able to remember it and what it does. And I say that this class of medication it has less sexual dysfunction. So what else do we need to know about Wellbutrin? It can cause a higher risk of what? Seizure for patients that, so that is why we say increased seizure. So because it can cause a higher risk of seizure, so you need to avoid it. So that means avoid patient with anorexia nervosa or dehydration. So any condition you know that makes the patient to be at risk of dehydration and anorexia nervosa, because anorexia nervosa, because these people are at risk of dehydration. We will still see what is anorexia nervosa. You see them vomiting. Any situation you know that patient to be at risk of dehydration, you need to avoid Wellbutrin because Wellbutrin causes the risk of what? Of seizure, very high yield. Then we have another class of medication which I was saying is one of the oldest. That is TCAs, tricyclic antidepressant. Another high yield one is another antidepressant. These are one of the older one, but we rarely use it now because of the side effects. So what are those side effects? They have more of anticholinergic effects, which is those dry mouth. Okay, and another thing here is that there is more dangerous in overdose, and that is why SSRI is still better off than any of them. In SSRI there is SSRI, you should also remember a black box warning for suicidality. So black box warning for suicidality. So, especially in adolescents. So, when you give it to adolescents, they need to monitor for signs of suicide. Okay, but then it's more safer during an overdose, unlike other ones. So when somebody overdose in SSRI, is the symptoms are more mild to compare with TCA and MAO. Okay. So another thing you need to remember as TCAs is what are the medication that is under TCAs. Amitriptyline, nortriptyline, imipramine. So how I remember this medication is that they ends in lane or lane, LINE, or they end in MINE. So it's either they end in lane or they end in mine. So that is where you have amitriptyline, nortriptyline, imipramine. So for example, they can ask you a question and say a patient is on amitriptyline, amitriptyline or imipramine. What antidepressant class of medication is that? That is TCA. Another thing you need to remember about TCA is that we use it for other conditions. We don't just use it for depression, we can also use it for chronic pain, like we mentioned, chronic pain. So the ones that we usually use for chronic pain is your SNRI, which I mentioned, TCA, and what? Gabapentin. Gabapentin is also used, but for the sake of the exam, the one that we use more is what? SNRI. But other ones, so you can still use TCA and gabapentin. Most of you know about gabapentin, so you can still use that. We also see it in migraine prophylaxis. You will see TCA in migraine. When we say that when we did neurology, we saw that under the treatment of what? Under the treatment of migraine, TCA can be used. But know the side effect of TCA, and it can also cause cardiac issue like QT prolongation. So any cardiac issue, so that means it can affect their heart. So sometimes it's also good, any medication that can affect the heart is also good to get the EKG. So it can affect the heart, it can also affect the blood pressure, it causes orthostatic hypotension. So the side effect is very important to know, very very important. Then we have another high yield medication here, which is the oldest antidepressant, but no longer used. You can they use it, but the only time they use it is when all the other antidepressants have failed. So your last option may be the MAOs. Okay, so this is the monoamino oxidase inhibitors. So under this medication, I always remember it as simple. You have seen the mnemonic before, which is no popular meds. So this is the mnemonics. You have seen it before. So no is your Nadel. Then P is your Panate. Maplan is your meds. So you can also use it to remember that way. Nadel, Maplan, Nadel, Maplan. Then the other one is Panate. Then the last one, which is meds, no popular meds, is your what? Map plan. Okay. So you can use this mnemonics if this one works for you, which is your no popular meds. You can use that. But sometimes if they want to be more fancy, no popular meds is very easy. But if they want to be more fancy, you can also use another mnemonics, tips. Tips is really difficult. So what is T? T is this one, tricyclopamine. What is I? Isocarbozide. What is P? P is your phenylazine. What is S? S is your selagine. So if they want to be more fancy, uh, but I know that these are really hard to remember, but those are the two mnemonics if you want to know the mnemonics. And we are not talking about Parkinson disease now, but always remember that seleginelane is also used for Parkinson. That's all. Is also a Parkinson medication. If you look at medication used for Parkinson, Selegin is there too. So you can use no popular meds, which is Nadel, Panet, Maplan. But if they want to be more fancy on you, you can also use tips to remember. Then another thing that is so high yield with MAOs is that you have to avoid it with what? Tyramine rich food. So those food that contains tyramine, and we know example like aged cheese, cod meat, fermented products. So you need to avoid it. And the reason some can also be like pep and pepperoni, all those things. So you need to avoid it because it can lead to hypertensive crisis. And we are still going to see hypertensive crisis, but you find out that hypertensive crisis is not a good thing. So that is why for this medication, that was the one that was used, the first that was used, but it has a lot of side effects, especially with the hypertensive crisis, which you know that hypertensive crisis is a medical emergency. So educate them to avoid tyramine diet, and you will also need to know the tyramine diet. Then we have another one that can be used. So these ones are called atypical. So we don't really know where to classify this one, but it is under atypical. So we have them here, but the one that is more high yield in the exam is Milteza, which is a Remeron. So Milteza, it helps especially when we use it more for appetite stimulating. So when somebody is depressed, the person may not want to eat. So, in order to stimulate their appetite, you are giving them antidepressants and then they can be able to eat. It stimulates their appetite. So, what you can give them is Remeron or Milteza. So, how do I remember that? M or Milteza, you can use it to remember meal, like Milteza, meal. So you give it stimulates their meal, it stimulates their appetite. Milteza, Milteza pines, Milteza, Milteza pine. It stimulates their meal, their appetite. Okay. So if this is stimulating the appetite now, what will you monitor for? You have to monitor weight gain. There's some patients that when they are on this, they start complaining about weight, a lot of weight, because now it has stimulated their appetite, they are able to eat. So that is very important. Then another medication here is trazodone. Everybody knows trazodone. So trazodone is another atypical one. Some people said is a sleeping medication, but it's used off label as a sleeping medication, but it's actually used for depression. So it's commonly used for insomnia due to its sedative effect. That is what we know. But that is usually for off label, but is an antidepressant. So what do we monitor here? It causes by by uh, priapism or priapism or priapism. So which is that prolonged painful erector, the painful erection without stimulation, okay, or without arousal. That is priapism. So that is what you need to know here. Very high yield. So it's used off label for sleep, which everybody, once you ask somebody antidepressant trazodone, what they will tell you is a sleeping pill. It's not a sleeping pill. It can help with sleeping, but it's actually antidepressant. So we have another one here, but focus more on milteza and trazodone. So we have other newer medication, which I said I'm not sure if it will be in the exam, but just know I've seen some practice question. That is why I had to put it here. So is esketamine. So this is mostly the ones newer medication. So it's a newer one. It's offering hope for patients who don't respond to the other ones that we mentioned. So, but that is it. So we say that it's specifically approved for postpartum depression. So after childbirth, postpartum. So that is the one, the newer ones. Then we have another class of medication. We have finished antidepressants, and I hope you learned something. I broke it down. I told you everything you need to remember. We started with SSRI, went to SNRI, went to NDRI, went to the TCAs, MAOs, MAOIs, then the atypical one and the newer one. So just know it. Even if you didn't learn anything, you must know your five or six classification of antidepressants. Then we have another class of medication which we call antipsychotics, very high yield. From one thing you will learn tonight is that you see under mental health there is five medications that you need. So we have done the first one. The first one is antidepressant. So we are going to the second one. The second one is antipsychotic. So what is antipsychotic? These are the medications that we use. Okay? We use it for schizophrenia, bipolar disorder, and psychosis or psychotic syndrome. So this is what we use. That is antipsychotic, and it's also classified into four class, but mainly two classes. If you read a lot of books, it is two classes, but it's just that some of them, when we look at it, we don't know where to actually classify them. I'm gonna show you what I meant by that. So if you read some book, it's going to tell you it's just two classes, which is first generation, typical, typical, then second generation, atypical. So if you look at this, the first generation is just typical. That means is a strong dopamine receptor blockage. So is blocking is a dopamine receptor. D2 is always dopamine receptor blockage. And I remember these two and three medication, haloperidol, chlorpromazine, which is the thorazine, and the flunazine. So you have to know your medication. You have to know your medication. So that is the first first generation, which is your first generation. So that is just the dopamine receptor blockage. Then we have another second generation, which is mostly the dopamine and the serotonin. Okay, so this one you have to remember. These are the most common one, which I always sing as a song. That is the cypressa, seroquel, respedal, cypressa, seroquel, respedal, cypressa, seroquel, respedal. They causes weight gain. Okay, so what you see here is that this second generation, the problem here is that second generation is is it has to deal with, but we'll still take it one by one. It has to deal with what we deal with here more is what for this second generation, metabolic syndrome. That was why I said it causes weight gain. Okay, it causes weight gain. But under, so that is what we deal with in this second generation. But in this first generation, what we deal here more is what? We deal more of we deal more of EPS and extrapyramidal symptom and neuroleptic malignant syndrome. You're going to see these two things. So these are the two side effects that is common with first generation. So when changes continue to happen, because of these two symptoms, EPS and NMS, the second generation was better because the second generation does not, it has more fewer symptom of this EPS and NMS. Okay, we will still see those things. But the third generation, which is also in the second generation, like I said, it depends on the book that you use. That is the dopamine partial agonist. So some book will tell you that the most common one there is Abilify. Okay, so when you see Abilify, you are going to see that it causes less weight gain. So let's say a patient wants something that will not cause them weight gain. You see that Abilify is more better option. So that's why I said book will tell you that it is in second generation, but then it is in second generation, but it's kind of a little bit different because it doesn't cause weight gain. Okay, then we also have the one that is a long acting injectables. So were very important. So you can classify your own under first generation and second generation, but I always like to separate Abilify because Abilify have lesser weight gain. So if they and another thing, it has lesser weight gain and makes patient more awake. So it makes patient more awake. So because it makes patient more awake, how do I it makes patient more awake? So how do I remember that? I remember it as A, as in awake. So as in awake, A for awake. So it causes more or less weight gain and it makes the person more awake. So which means it can cause insomnia. They stay awake. So you can give it to them more in the morning. Okay, more in the morning so that it doesn't keep them awake in the night. Then we say that the second generation, what makes them atypical is that it doesn't have just dopamine. Dopamine is anywhere you see D2, that is dopamine. It also block the serotonin syndrome. So because it's also block the serotonin. So because it's blocking the serotonin, so that is why they have less EPS and less NMS. So what you deal with here is metabolic syndrome. We will still talk about that. So the first one, which is the typical, I told you that is the haloperidol, chlorpromazine, and flufenazine. So what do you need to remember here? This is the first generation. It has more extrapyramidal symptom, very high yield. It has more extrapyramidal symptom. We will still see what is extrapyramidal symptom, and it also have the neomalignant syndrome, which is neuroleptic malignant syndrome, MS. Okay, so and this one blocks only the dopamine. I've said this so many times, but the second generation is block more the dopamine and the serotonin. So we have the second generation. So know your first generation. For example, Hadol and the chlorpromazine is always high yield. So they give you example, a patient is on Hadol, a patient is on haloperidol. What do you monitor? So what you monitor is what we call EPS or enuloleptic malignant syndrome, but I will still show you that. So we have another class of one which is the atypical. Atypical. So the atypical we said is blocking both the dopamine and the serotonin. So what are those medications? These are the medication here. I called it Zyprexa, Seroquel, Respedal, also Clozaril. This Clozaril can also have a class of its own, but it's still under atypical. Like I was explaining, it's still here. So what do you need to remember here? We also have Jodon. Jodon is mostly injection. What you need to remember here is that they have lesser, those are the notes you need to be making, lesser uh, extrapyramidal effect and lesser NMS. And I mentioned, okay, this second generation, which one should you remember most? Example, Resperadone. Okay, Resperadone can also cause galacturia. Okay, so when there is a blockage of this dopamine, it might lead to galactorrhea. So when this patient is taking Resperadone and patient tells you they are having discharge from their nipple, like a man having discharge from their nipple, galactorrhea, so they need to DC it immediately. Resperadone. Resperadone. Then we have the olanzapine. How do I always remember olanzapine? I have a little way I remember my own thing. O for obesity, or O for obesity. This one is more risk of weight gain. O for obesity. Olanzapine. Olanzapine, which is Zyprexa, Seroquel. So that O, they are always at risk of obesity. How do I remember quietapine? Quietapine is Seroquel or Seroquel. Okay. How do I remember that? Seroquel, I always remember my S as sleeping. They are the one that more sedative. So we kind of don't want to give this more to an elderly patient because, like we said, it's going to make them more sedative. Most Another way to remember is quietapine. Quiet, maintain quiet. When you maintain quiet, people sleep, or you can use S. So Sometimes they ask you some of these side effects I'm sharing, so that is how to remember. Another one is clozapine. Clozapine, C clozarel. Sometimes you use the word monitor closely. C for closely. C for closely. So how do you remember closely? You have to monitor for blood monitoring because they are at risk of agranulocytosis. We are going to see that, okay, which is depletion of the WBC, and it makes them to be at risk of a lot of infection. So that one is C closely, monitor closely for agranulocytosis. Monitor closely for agranulocytosis. Then we have our Jodon, Jodon or Zyprasidone. Zyprasidone, I always remember is the one that is more less more less weight gain. So you can call it a little zebra, or you can just say ZAL, like Zal, ZAL. Okay. So those medication, those ones. So one of it is this your Jodon. Okay. Jodon. So these ones are the one that causes less weight gain. So you need to remember that. So that is your Z is your zypresidone, which is your Jodon. Another one is your A. A is your Abilify. Remember, I was saying Abilify can also be in this group, but I separated it from this group because it's more, they have more lesser um weight gain. So these are the ones that causes lesser weight gain. Zypresidone, which is your Jodon. Okay, another one is the one we call Abilify. Another one is the one that we call what? We call it Latuda. So I always remember it as ZAL. If you don't want to call it ZAL, I also call it a little zebra. So if you turn it around, a little zebra. So that is another way to remember. So a little zebra is A is Abilify, L is Latuda, Z is zebra, and Zaprazidone. So this one causes less weight gain. So let's say they ask you a question, which of these following is will cause lesser weight gain for the patient? The answer is zy- zypresidone, Abilify, and Latuda. Okay. Then we have another class, which is the class I was talking about, Abilify. Abilify is still there. We still have this one because these ones they causes less weight gain. That is the major thing here. So that is why it looks like it's a different class, but some people can put it in class two. Okay. Then we have another one, that clozapine I mentioned. I mentioned it here. Clozapine is still here. They can still be in second generation, but then this clozapine is high yield. As I was mentioning, that this clozapine you have to monitor for agranulocytosis, which is a severe reduction in white blood cell. So when there is a reduction in white blood cell, this patient will be at risk of infection. So that is why we use the word close the pine, closely monitor, close the pine, closely monitor the white blood cells. So your answer in the exam might be to monitor the white blood cell. It can be to monitor for infection because this patient now is at risk of what? um, Reduction in white blood cell, very high yield. Just 1 minute. So that is very, very, very important. Granulosa. So remember the word. So that is one thing about mental health I have seen. It looks like it's challenging, but it's not. If you learn just simple way to remember the side effect, like I mentioned about risperidone, that is the one that can cause galacturia, which is that breast milk secretion. So when a patient is on risperidone and they tell you that it's secreting milk, the answer in the exam is discontinue the medication. Then olanzapine, which is your Zypreza. O for obesity. This one is the one that causes more obesity. Okay, quietapine, quiet, let me sleep. So you can use quietapine or S, sleep. So this one is more sedative. But if you remember when I mentioned the Abilify, I say remember Abilify can also be in this class too, which I have emphasized so many times. It just depends on the book you are using. So you see that Abilify makes them to be awake. So in the exam, which one will be safer for an elderly patient? That will be Abilify, because Abilify keeps them more alert, awake, but you want to give it more in the morning. Then we have CLO, clozapine, monitor closely. So monitor closely for agranulocytosis. So your answer may be other WBC. Your answer may be monitor for infection. Answer may be they require a mandatory regular blood monitoring through the olanzapine clozapine REM program. So this is just a close monitoring because of what we say it can cause. So they have that program, REMS program. REMS program is just to monitor there, because there is a breakdown, like when this is this level, those white blood cell count, but I'm not here to talk about that. It's more detailed. It's people that wants to study more. It will show you the the levels of the lab. Like they start breaking down those white blood cell labs and tell you when it's less than 1,000 and all that. But we are not going there. So they have to monitor them closely. Just know the simple thing: closely, monitor them closely for granulocytosis. Then these are the injectable ones. The injectable ones, they can give them, and some of the ones we have mentioned can be there, which is also injectables. Because the reason we also do injectables, it depends on your question. I'm not too sure, but sometimes if a patient is not doing well, like they are at the risk of relapse, so you are not going to be giving them the oral one. You can change it to the injection. But there is also a formula on that, which I don't think anybody will start asking you, because that formula, you multiply it by 20 of the daily doses. So let's say patient is getting 5 milligram, but I say that is more deeper for you people. But there's something like that. They monitor they get the daily doses, multiply it, and they give them. So, but you can't give them, for example, Hadol, you can't give them more than 100 milligram. So when you give them the remaining one, you can tell them to come back in 1 week. But it's just what you just need to know is that when a patient is at risk of relapse, they can give them the injection. But remember, this is um, we are just family practice or adults. So those ones are more in depth. So another medication you need to know now is, we call it the mood stabilizer. So that is the next class of medication. Remember, I told you 5 classes of medication to know. The first one was your antidepressant. We have covered the antidepressant. That was where we started from, which is the SSRI, SNRI, NDRI, TCAs, MAOIs, antidepressant. Then after we finish atypical antidepressant, after we finish that, we went to antipsychotic. And I say antipsychotic is the one we use for schizophrenia, bipolar. Okay, we have finished that. So the one we are entering now is the mood stabilizer. Okay, mood stabilizer is always used for bipolar. So if you look at your bipolar condition, you see simple way to remember bipolar, and it's becoming interesting the more that I study on this, read it. Bi is two, two. When you say bi, is always two. So these people that have bipolar, they are on two poles. That is simple way to remember. They are on two poles. One pole is manic. So you are going to see they have a manic stage. Another pole they are in is depressive stage. So when we say that somebody is bipolar, we say that this person have mood swing. Some of you use the word and say, oh, this person have mood swing. Okay, so that is the bipolar. You say the person have mood swing. So the idea of the bipolar is that the person is between two poles. So it's either the person is what is manic, or the person is what depressive. Okay, so when this person is manic, the gold standard, this is high yield. The gold standard for mood stabilizer to stabilize the person's mood is lithium. So we are going to look at lithium. Lithium is a very high yield thing for the exam. So one thing you need to know about lithium is that lithium has a therapeutic serum, a narrow therapeutic serum level. What does narrow therapeutic serum level means? You see, 0.6 to 1.2 is the range. The level that can cause toxicity is just a little range. So if this person go beyond 1.2 and enter 1.3, it's just narrow therapeutic range. The person may start having all those toxicity, especially once it gets like 1.5, you have to stop the medication. So it has a narrow therapeutic range, and it also means that this the kidney, lithium is very important because the kidney has to be functioning very well. Okay, it can cause kidney problem. So I always remember the medication that can worsen lithium, or that can affect the lithium. Okay, so it's usually your NSAID, it's usually your thiazide. So I call it NTA. What is NTA? NSAID. When somebody is on NSAID, let's say somebody is taking any NSAID that you know, okay, be careful because NSAID, it can worsen the renal clearance. Another one, like we said, is a thiazide. So they can give you a question: patient is on thiazide diuretics, what do you monitor? You have to monitor this because it can worsen it. Then the last one is AC inhibitors. AC's inhibitor, okay? So, which is just angiotensin converting enzymes, okay? So, very important. What are the labs we need to monitor when somebody is on lithium, very high yield? You need to monitor, we said that we are monitoring their blood level, okay? So, you need to monitor their thyroid, TSH. We need to monitor their kidney, very important. We need to monitor their electrolyte. The electrolyte we are looking at here is mostly the sodium. And also we need to monitor pregnancy. pregnancy is one of the things. So it requires monitoring pregnancy tests. Pregnancy test is very high yield because we will see one of the things that lithium can cause. Okay, so that is it. Then for lithium, you have to educate this patient. They have to maintain. So very important. If a patient is on lithium and patient is having diarrhea or anything that will make them to lose sodium or lose water fluid, they need to report. That can be your answer. So they need to report any instances of sodium loss. So you want them to maintain on hydration. So they need to maintain hydration and sodium, salt intake. So very very important because if not, it can cause toxicity. Then we have another mood stabilizer, which is a anticonvulsant. So under anticonvulsant, these are the two. One is valproic acid, okay? Another one is carbamazepine. These two, which is we also have the tegretol, okay? So for valproic acid, it's very important. They need to monitor their liver, because liver, this is very high yield because the liver, this patient, when a patient is on valproic acid and patient starts exhibiting confusion, disorientation, that can be as a result of elevated ammonia level. So they have to monitor their liver the way we are monitoring lithium for kidney. This Depacort, some people call it Depacort or valproic acid. So that is your liver. Monitor your liver. When these patients start complaining of this, or when patients are having disorientation, it can be that the ammonia level is high. Then we have the carbamazepine, which is so remember the other name, Depacort. So we will still see some of the neural tube defect. Depacort causes neural tube defect. Um, Lithium causes Epstein anomaly. So we'll still see that. We have carbamazepine, which is the tegretol, another name. So for tegretol, we need to monitor the liver, monitor CBC. Okay. So, but this is very high yield because it causes a side effect, and one of the side effects it causes is Steven Johnson syndrome. So when this patient is on carbamazepine and patients start complaining of those rashes, we know what Steven Johnson syndrome is. So you tell patient to report. But that is anticonvulsant we use. And another thing you need to remember about anticonvulsant is that it reduces the effectiveness of oral contraceptive. Because it reduces the effectiveness of oral contraceptive, they need to use two forms of birth control. It reduces the effectiveness of oral contraceptive. So they need two forms of birth control. So we have the latrimogen. So this latrimogen now is when a patient is on the depressive mood. Remember, I told you that bipolar is what you know as mood swing. You see them, they are manic. We will still see what is mania. Very, very hyperactive, grandiosity. We will still come to that. But there is another pole they may be, and that pole is the depressive mood. So when they are in that depressive mood, what we give them is latrimogen, which is your lamictal. Okay. So for this medication, also to monitor Steven Johnson syndrome. The same way you are monitoring Steven Johnson syndrome for carbamazepine, Tegretol, the same way you need to monitor latrimogen for Steven Johnson syndrome. Then we have another class of medication, which is the atypical antipsychotics. So these ones are no longer lithium, anticonvulsants, or latrimogen, but you can still use them for mood stabilization. So what are the example of those ones? The same one like we mentioned under atypical antipsychotic, which is your seroquine, Abilify. So we can still use these ones. Okay. So sometimes it's just to let you know that this can be used to also treat the mood. Then we have other moods. These are the other mood stabilizing agent which we you need to know. Topamax, calcium channel blocker can be used, and trileptal. But we have mentioned the major three you need to know: lithium, the viporic acid, the carbamazepine. Okay, those two. Then, in summary, you need to know the gold standard is what we said is lithium. Okay, but I said lithium have a very narrow therapeutic index, so you need to monitor their kidney. This word I am saying is very high yield for the exam. You need to monitor their kidney. You can also choose to do the convalescent, which is where you have the Depacort and the Tegretol. The ones that is the atypical, you can also use that. Then we have anxiolytic. So this is the fourth class of medication you must know in mental health. Anxiolytic. So what is this anxiolytic? Anxiolytic is made purposely for what? Anxiety. It's mostly for anxiety. I know that SSRI you can use it for anxiety, but anxiolytic is more anxiety. Okay, because if you give normally SSRI, it can take 6 to 8 weeks to start working. So, but if this patient really have anxiety and you want to give them something that will take 6 to 8 weeks, it's not going to make sense. So what they do is that they put them on SSRI and then they give them anxiolytic. Anxiolytic is usually short term. It shouldn't be more than 2 weeks. I know that some places you see they put it PRO and they put it long time, but it's just for something that is just for short period of time, pending on when the SSRI start working. We don't want to use this for a longer time. So we use it to reduce anxiety, promote calmness, and aid sleep. So let's say somebody wants to go for dental procedure. They are very nervous. They can use it. So anxiolytic is what we use. But what are those anxiolytic? The first one is the benzodiazepine. Ben, benzodiazepine. If you remember Benz, you know what is Benz, the car that is Benz. You know how Benz drive strongly, fast. So under this, we have the rapid acting, short duration. That is your um, alprazolam or Zenas. Okay. So this Zenas is they can ask you what is the shortest one, what is the longest one, very high yield in the exam. So the one that is shortest, the one that is okay, you need to know. So the if somebody have a like I've explained, you can give it to them just before the SSRI start working. So we have the lorazepam, which is the Ativan. Ativan is intermittent acting. Diazepam, which is the Valium. Okay. Clonazepam, which is clonopin. So if you can remember it again, or prazolam, which is your Xanax. Lorazepam, which is your Activan. Diazepam, which is your Valium. clozapine, which is your clonopin. Clozapine, clonopin. We have the one that is non benzodiazepine. Okay, so these ones too, it can also, we use it, we mentioned the gabapentin. We can also use it for neuropathic pain, but off label they can use it for anxiety. Okay, so some of it, even Larica, so off they can also use it. We know we use it for pain, but it can also be used for anxiety. Then SSRI, like I mentioned, SSRI is also used for anxiety. But what I mentioned is that they start patient on on SSRI, but then they have to give them benzodiazepine to be able to do what? To walk fast, fast before this SSRI start working. But also know that SSRI is anxiety medication. We have said it already. And they can also use SNRI before the benzo and SNRI start working. So we have another class that is atypical anxiolytic. So why is atypical anxiolytic more better? The one that we have there is buspirone, which is Bospa. So Bospa is an anxiolytic, but it works differently from benzodiazepine. So this one is more better because it doesn't provide immediate relief, okay? But this one, it has more lesser addiction, because the problem with benzodiazepine is that benzodiazepine have more addictive nature. So that is why we don't want to give benzo for a long time, because of the risk of what? Addiction. That word is very high yield because of addiction. So we rather give them um buspa. So how do you remember benzo? Remember I say Benz, like somebody driving Mercedes Benz. When you are driving Mercedes Benz, you are going to drive faster, which is the one that is more addictive than Bospron. Bospron is like you are driving a bus. Bus may be more slower because it will stop and pick up people, stop and pick up people. Even though it's stopping and picking up people, it may require like it doesn't provide that immediate relief, but at least there is more lesser side effects to compare with benzodiazepine, and there is also less risk of what? Less risk for dependence. So that is why we have no dependence or withdrawal risk. So this is high yield. Is That is why it's better than benzo. Benzo have more risk of what? Addiction. Withdrawal effect is more higher. Okay, so that is another medication we can use for anxiety is beta blocker. So we know beta blocker as our propanolol. So that is why some people, because they have anxiety, it can be test anxiety, it can be stage anxiety. They don't normally have anxiety, but once they have an exam, they have that anxiety. And that is why some people, it's hard for them to pass an exam. We call it situational or performance anxiety, or even speaking in the public. So that is why beta blocker, sorry, is used. So for beta blocker, like some people preparing for this exam, they can request their provider, and their provider will give them something for their anxiety. So one of the things they can give them for the anxiety is beta blocker, because so that the anxiety will not be too much for them to take the exam. But what you need to know is that this beta blocker, it can also cause bronchospasm. It can cause, and it can also It says they can have it are primarily cardiac medication. So it's medication we usually use for hypertension. Okay, but it can also cause rapid heart rate, trembling, sweating, and bronchospasm. So we have another class of medication. Remember where I started from? Five medications to know for this exam. We started for SSRI, SNRI. The other one is a no, sorry. We started from antidepressants. Sorry, from antidepressants to our what? To our mood stabilizers. So let me recap. We started from antidepressant to antipsychotic, from antipsychotics to mood stabilizers, which is the third one, from mood stabilizers to anxiolytic, which is the fourth one. So the fifth one now, you must know for the exam, is the medication we use for ADHD. Okay? At least you need to know these five classes of medication that we went through today. So the ADHD medication is broken down into two parts. The first part is the non-stimulant, and there's another part that is what? The stimulant. So the ones that are the stimulants, so which is amphetamine. So what are those ones that are stimulants? Adderall. Okay. So and all these names lisdexamfetamine. Okay, but know that it is stimulant. One thing you need to know here is that they can ask you ADHD medication that is stimulant. Example is a simple one. You can see amphetamine or Adderall. That is stimulant. And one thing about stimulant you must know is that stimulant decreases appetite. You know, when you see these things in real life, I have seen this. I've seen a younger or an adolescent um taking this medication, and for me, she looks so skinny. I'm not saying that skinny is bad thing, but for me, because there's a way I, with the knowledge that I have, so I asked her a question. I said, "Do you even eat at all? Are you eating well? Are you sure your eating is good?" And the first thing she told me was like, no, she doesn't eat well. I said, what do you mean? She said she have decreased appetite. I said, why? She said, because of the medication that I'm taking, you know. So when I asked her the name of the medication, she told me. Then I have to ask the mom. I said, do you know that this medication is causing this? The mom said, yes, she knows. So that is why the mom said that the girl can stay almost morning till night. She won't even remember to eat because she's not hungry. So what they are doing is they are giving her constant reminder. They have to buy protein shake for her. I'm just telling you to know the level of when we talk about appetite suppression. They don't have the appetite. So when you see these patients in real life, these are the things you need to know. They can encourage the mother, they can have a timer to remind the child to constantly eat when they're supposed to eat. And also, it can increase their heart rate and their blood pressure because it's a stimulant. We know what the stimulant can do. So, but for the purpose of the exam, it decreases their appetite. So, the answer can be to monitor their weight because if you monitor their weight, that is how you know that their appetite is what? Reduced, that they are not eating well. It can be insomnia. Like I said, it keep because it's a stimulant. Stimulant tends to keep people what? Very active. Okay. So then we have another one that is a stimulant after the amphetamine. Another stimulant is what? Methylphenidate. Methylphenidate. So this is where we have our re- rit- re- Retaline. I'm sorry if I'm not calling all this well, but you can see the names. So that is the name of the medication, that Retalane. Retalane, okay. We still have other medication there, Concerta, Focalane. So, but once they mention this, what you just need to know here is which one is stimulant. The ones that is stimulant is methylphenidate and the what? And the amphetamine. Then we have the ones that is not okay. This one we also have the norepinephrine reuptake inhibitor they can use. So in this one, example is your Stratera. If you have heard about Stratera, which is the atomoxetine, atomoxetine. Okay. So for this one too, they have to monitor the liver, fatigue, decreased appetite. Then we have the alpha adrenergic agonist. They can also use this one. That is where you have the guanfacine. So this one is a non-stimulant. So if they ask you what is the non-stimulant that you can use, that is your guanfacine or clonidine. So what do we monitor here? We monitor for hypotension. Unlike the stimulants will cause hypertension. Non-stimulant will cause hypotension, bradycardia, sedation. So that is this non non non-stimulant. Please pay attention. So how do we choose the right ADHD medication? Usually stimulant is the first line, except if there is other things. But for the purpose of the exam, what you just need to know is that if they ask you which one is stimulant, you need to know that, and which one is a non-stimulant. The one that doesn't have stimulant is the guanfacine and the clonidine. But for stimulant is the methylphenidate and the amphetamine. Okay, so this is a summary of everything that we went: antidepressants, antipsychotic, mood stabilizers, anxiolytic, and this is a so let's talk about lithium. I have mentioned a little about lithium, and I said lithium have a serum therapeutic index of 0 point the range of therapeutic range of 0.6 to 1.2, very high yield. You must know this for the exam. And lithium is the gold standard for treating mania. Gold standard. Another important thing is that it demonstrates significant anti-suicidal effect. So that means it's really good for in bipolar disorder, anti-suicidal effect. So at least there is a risk of reduction in suicide. Anytime the range goes higher than 1.5, like I said, they have to discontinue it immediately. They have to discontinue it immediately. So what are the baseline labs? We mentioned it before. Thyroid function, you need to monitor the TSH. Pregnancy, okay. Renal function, which is your creatinine and your BUN, and cardiac function, EKG, okay. So what are the side effects of lithium? Very high yield. I mentioned it before. So we monitor the TSH. So you need to monitor the side effect is that lithium can cause hypothyroidism. It can also cause weight gain. It can also cause fluid retention. But remember, it can lead to fine hand tremor. Yes, you can see that fine hand tremor starting, but once you have coarse tremor, then that is toxicity. So the answer in the exam may be a patient have lithium toxicity. What are the signs of lithium toxicity? It can be hypothyroidism. I didn't say hyper. Hypothyroidism. Quas tremor, you know, mental cloudiness, but you must know the CNS side effects. Then lithium, other side effects, dermatological, it can cause the maculopapular rash. Then GI is also high yield. All the GI symptoms, diarrhea, vomiting, abdominal pain, anorexia, very high yield. Renal, it can also cause anything about diabetes. Remember, when you talk about pathophysiology of sodium, water, reabsorption, all those things, but we're not there to talk about it. But renal, it can cause diabetes insipidus. So under cardiac, it can cause T wave inversion, very high yield. Lithium causes T wave inversion. Remember, we said, if you remember the labs to monitor, we said EKG. So because it can cause what? T wave inversion. Okay. And we also said that they need to monitor their kidney. Don't forget that. And I said maintain hydration. They need to be maintaining their water intake. Avoid NSAID, not just NSAID. Remember the three NTA that I said: NSAID, thiazide, and also angiotensin converting enzyme inhibitors. Okay. Then another one is the Depakote. So Depakote has a therapeutic range of 50 to 100. And one thing about Depakote you need to know is that it can cause neural tube defects. That is why those things you call spinal bifida. So the one for lithium is Epstein anomaly. The one for Depakote is what? Spinal bifida. Anything about neural tube defect. So you can encourage the pregnant woman to be on folic acid. So that is the side effect. It can cause neural tube defect, exactly what I just said, spinal bifida. And I said for Depakote, you need to monitor for the right upper quadrant pain, which is that liver. Remember. Then we have our MAOI hypertensive crisis. Remember when I talked about MAOIs, I said that one of the side effects there is that it causes hypertensive crisis. So what triggers of this hypertensive crisis? We say that is thiamine diet. Okay, it's thiamine diet, and we say that is a life-threatening emergency. Okay, so what are the things that MAOI can interact with? It can interact with the demerol to cause serotonin syndrome. It can interact with other antidepressants to cause more problem. It can also interact with decongestants and asthma medication, and it can also interact with stimulants. So, what are the symptoms of hypertensive crisis? Simple. If you know all the symptoms of when somebody have a high blood pressure, that is what you are expecting here. So, you are going to have elevated blood pressure, explosive occipital headache, facial flushing, palpitation, pupillary dilation, diaphoresis, fever. So this is a medical emergency. So whatever happens now, you don't know. What you need to know is to send them to the hospital. Okay, send them to ER. So at the ER, they're going to stop the offending agent. They're going to administer phentolamine. They're going to monitor their blood pressure. They're going to do supportive care. But this is primary care. So you are not dealing with emergency. Then the one for this was what I was talking about, very high yield. Tetrogenic risk. Tetrogenic risk of psychotropic medication. Benzodiazepine, benzo, can cause floppy baby syndrome. So if you remember benzo, I say when somebody is in Benz, when you are driving a Mercedes Benz. So floppy baby syndrome, it means the baby will not have balance. It's imbalanced situation, floppy this thing. Benzodiazepine can also cause cleft palate. Cleft palate. Remember the floppy baby syndrome, which is something about uh, imbalance, okay, in the movement. Then floppy, like floppy baby. Then carbamazepine, which is Tegretol, can cause neurotube defect. Lithium, I have mentioned it a lot. Lithium causes Epstein abnormally, and especially it should be avoided in the first trimester. As much as it is possible, you can avoid lithium in pregnancy, but if you cannot, then they have to avoid it in first trimester. Then we have the Depakote. Depakote can also cause spinal bifida and neural tube defect. Then the lacrimogen can also cause the Steven Johnson syndrome. And I mentioned the Steven Johnson syndrome, which is that they will start having sloughing of the skin. Their skin will start peeling, and it can be caused by lamotrigine. We have talked about that. Carbamazepine too. Carbamazepine, the difference between lamotrigine, which is the Steven Johnson in lamotrigine, and the Steven Johnson in carbamazepine, is the difference is that carbamazepine is usually more linked to genetic risk factor of people that are Asian population. So if they want to be more specific in the exam and they tell you that this patient is Asia population, what do you screen? There is an allele that you screen, which is the HLA-B1502. This, when you screen for people like this, it shows they may be at risk of Steven Johnson syndrome. So the only difference is that the one for lamotrigine is just general. But when they are specific and tell you that this patient is Asia population, then you know that it's carbamazepine. Then another thing I was talking about is that this ANC, anytime it falls less than 1,000, that was what I was saying, because it causes what? Breakdown of white blood cell, agranulocytosis. I mentioned this so many times. So they monitor this ANC. They are part of that white blood cell. We are not here to talk about labs, but that is how to remember. And carbamazepine can also cause the aplastic anemia, agranulocytosis, and genetic risk factor for people of Asian population. So they need to monitor the carbamazepine. Then we have the extrapyramidal effect. Now we are going to another important thing. So when we talked about the antipsychotic, if you remember, I believe I would, so this is slide 56. So when we talk about antipsychotic, let me see, antipsychotic medication. Under antipsychotic medication, yes, if you remember this slide, I said that this first generation, the problem with this first generation is that patient is at high risk of EPS and NMS. That was what I said here. But the second generation is mostly metabolic syndrome. Metabolic syndrome is basically weight gain, hypertension, hyperlipidemia. So those were the metabolic syndrome. But I mentioned that this first generation is more of APS and NMS. So that is what we are going to look at now. So when you put a patient on antipsychotic, you need to monitor EPS. So what is EPS? Extra pyramidal side effect. If you watch my the other video, I kind of use these words here to remember. Like the A, I use it to remember akathisia and echinacea. And T, I use the T to remember tardive dyskinesia. Okay. Then we have the D. I use the D to remember dystonia. Everybody study differently. This is how anything that I study, I find a way to picture it in my brain so that I can always remember it. Once I picture it in my brain, even if you come many years later to ask me this, the picture will be flashing in my brain. Okay. Even if you remember, once you look at it again, it's easier to remember. I don't just read, study, I analyze, I mentalize it. It's just because if you read this, it disappears like that. But when you break it down, how do I remember this? So that no matter how the examiner asks me question, I can be able to answer. Then P is your what? Parkinson. Sometimes we call it Parkinson, sometimes we call it pseudo Parkinson. So this is the extra pyramidal effect. So when you put somebody on first generation typical antipsychotic, these are the things you must monitor. So how do I remember these things? The first one is dystonia. It doesn't matter when they say that it occurs. Some people will say, "Oh, this one occurs the first few days. This one occurs first week. This one." It doesn't matter when it occurs. What matters is they are monitoring these symptoms, and they can ask you these questions on these symptoms in the exam. So let's look at the acute dystonia. Acute dystonia always has to do with muscle. Anything dystonia, it has to do with muscle spasm of the face and the neck. Okay. Of the face and neck, like a painful contractions, like facial grimacing. And another word there is oculogyric crisis. Okay. Oculogyric crisis. It usually look like something like this, but this one is more of tardive. Okay. But that is it, acute dystonia. So you see that these are the symptoms to monitor here. It always has something to do with neck, pain in the neck. Okay. So dystonia, acute dystonia. So when they are on that APS, they need to start monitoring those things. Very important, very high yield. So dystonia, it looks like their neck, they are having contraction. Okay. Even it looks like their limbs, everything is not, it's like they are pulling their neck. So we have a lot of pictures on that, how the person might look, but that is dystonia. So that is your dystonia. Oculo 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 oculogeric crisis. So let me show you how that might look, but you will see that everything that has like the muscles. Okay, the muscles. So let's see, oculogeric crisis. And like we said, when they are on a antipsychotic and patient is looking like that. Okay, patient is looking like that. I've seen, if you do, like if you see them, they may be looking like that. This is a picture from the internet, might not be a true, but just so something like this. Okay, it can be that dystonia, painful contraction, facial grimacing. um it can be often mistaken for agitation, but that is your dystonia. So please remember that that is why all these antipsychotic, like I think this might be a good one just to remember all these things. Pictures gotten from the internet. You can also go. So this is a picture for all these symptoms we will talk about now. I think is a good one. Okay, all of them gotten from the internet. So that is it. Dystonia. You see the facial grimacing, involuntary upward movement of their eye, muscle spasm of the tongue, laryngeal spasm. So that is it. Then after that, the next one is akathisia. How do I remember akathisia and akanesia? How do I remember? In akathisia is more of kinetic. Kinetic, people say movement, kinetic. So this patient is going to be more of restless. When they tell you patient is restless, pacing, rocking, constantly moving, and patient refuse to stay still. When you see a patient on these medications, they refuse to stay still. They cannot stand one place. They are going up and down. So sorry, I didn't finish the treatment for dystonia. Treatment for dystonia is usually cogentin or oral anticholinergic. Okay, and you need to adjust their medication. Very important. But the one for akathisia, they are always restless, pacing up and down, constant movement. They are not stopping. They keep going. So these people you can give them beta blocker, and we so for beta blocker you need to avoid it for people that have asthma. It can cause bronchospasm. Then how do I remember? K for kinetic. Okay, kinetic. And another way I remember it is that they keep moving up and down, moving up and down. But how do I differentiate it with this akinesia? Care is still there, but I look at another letter N. Since I started doing it like this, it helps me. That is, I use it to remember nap. When somebody is napping, like when you are sleeping, or when you took nap in the afternoon, right? You are tired of initiating movement. So this N here, these people find it difficult to initiate movement. That is why you may mistake them as lazy. They have laziness or negative symptoms. It is difficult for them to start. When you wake up from sleep, I don't want to use the word sleep, because if we use sleep, we might not get what the way I remember it. Okay. So how I remember it from this one is akathisia. There is no N here. Akathisia is always moving up and down, restless, pacing, constant motion. But when you remember akinesia, because how they do this in the exam is that they explain it for you and they tell you what is the symptom. So when they tell you that this patient find it difficult to initiate movement, like when somebody wake up from their nap. So let me put it, napping. I don't want to put another thing, but if you can remember my own, fine. If you have your own, fine. But I know that people after napping, they are so slow, sluggish. So for these people, they are slow, they are sluggish, they don't want to initiate, or they have difficulty initiating movement. But we have this group of people, their own is what? Pseudo Parkinsonism. So it shows that they have like symptom of Parkinson. That is that one. Stop posture, shuffling gait, rigidity, tremors at rest. So they may be showing signs of, so when this patient is on antipsychotic and patient is showing symptoms of Parkinsonism, what do we call that one? Or patient is showing rigidity, tremors at rest, shuffling gait, then that is Parkinson, pseudo Parkinsonism. Then we have the last but not the least, which is the tardive dyskinesia, very high yield. So how do we remember this tardive dyskinesia? You see, tongue protrusion, lip smacking, chewing motion. That is tardive dyskinesia, very high yield. All these things that I mentioned, they will explain it to you. And when they explain it to you, you need to choose the answer. Is this acute? When they tell you anything about muscle spasm, involuntary upward movement of the eye, acute dystonia. When they start telling you about akathisia, patient is restless, patient is moving up and down, patient cannot stay still, that is akathisia. But when they say akanesia, that one is a difficulty initiating movement after napping. Patient is so sluggish, tired. It appears that they look lazy. So any of these things they can tell you, especially the word lip smacking. Patient present with lip smacking, chewing motion, tongue protrusion. You know it is tardive dyskinesia. Then another symptom we say that this patient that have antipsychotic may have is neuroleptic malignant syndrome. So what is in this neuroleptic malignant syndrome now? The problem here now is what? They are on too much antipsychotic. So you can say too much, too much antipsychotic, which is that usually the first generation. So when this patient is on too much antipsychotic, this patient will start having hyperthermia, extreme muscle rigidity, mutism. But the major thing for the exam, mutism is important for the exam, but another important thing for the exam is elevated creatinine um, CPK kinase. Okay, then we have myoglobulin and elevated white blood cell. This patient will start having white leukocytosis. So this is not just when you put a patient on antipsychotic, you ignore the patient. You have to monitor this neuroleptic malignant syndrome. So how do we manage this? At this point, they need to go to ER. But if they are going to ER, they are going to stop the medication immediately and they administer bromocriptine. They administer bromocriptine or they administer dantrolene. So somebody will say, how do I know when they administer bromocriptine? That is just the dopamine, okay? Is dealing with the dopamine. But dantrolene is when they have rigidity. If they tell you that this patient have signs and symptoms of rigidity, then you are going to use dantrolene. Dantrolene will relax them. But other than that, we use the bromocriptine. Then you must know your suicide risk at assessment. Suicide risk assessment is very high yield. Which patient is at risk of suicide? The most important one is a previous anybody that have attempted suicide in the past is the highest risk. Other demographic risk factor is like the age. The older the person gets, the gender, more in male, the race, white race, okay, white race. Then another one is marital status. When somebody is single, it can lead to loneliness. Then other factors can be psychiatric disorder, substance abuse. Then when somebody is living alone, recent loss, isolation. So know your signs and symptoms. Like we said, white male is usual. So and two is more in male more than female. But then female attempt suicide more, but they don't complete it. They don't. When you compare man and woman, woman might attempt, but they don't complete it. But men, they may complete it right away. So that is another difference. Then you need to know about the cage questionnaire. What is the cage questionnaire? When somebody is an alcoholic, you need to go through this. Know the mnemonics. C is for cut down. Have you ever felt you should cut down when you're drinking? A is annoyed. Have people annoyed you by criticizing your drinking? G is guilt. Have you ever felt guilty about your drinking? E is eye opener. Okay, so these are the things you need to ask them question, and you must know these mnemonics because sometimes they can ask you all of the following are cage questionnaire except, and one of the things they may put here is fighting. It doesn't show there's any fighting. Okay, so no, cut down, annoy, guilty, and eye opener. Know your fetal alcohol syndrome. When a pregnant woman is taking alcohol, these are bound to happen. Okay, no matter, even if it's a small alcohol during pregnancy. So this is very easy to remember. You can use a lot of mnemonics that you want to use. Some people, I think there's one you can use, which is the seat silt. I think I usually use this one, silt. But I think it's usually easy. Anytime they mentioned those things, you will remember. So what is S? Uh, okay. So what is S? Short palpebral features. Then I is your what? Um, let's see, because it depends on what the ones that they are using. But let's see. L is your low birth weight. T is your, what is T again? I know there's T is tiny, something here, tiny upper lips. Tiny upper lips. Then S is a smooth phytrum. So you can use this silt. S short palpebral. L, yeah, I think I is silent. L low birth weight. T tiny upper lips. S smooth phytrum. So, but whatever work for you, okay. But I kind of have a way to remember my thing. Then we have the delirium versus dementia. Delirium always has to do with acute onset of something, which usually it can be as a result of medical illness, infection. I have seen this delirium in patients. So these patients do not have any dementia. But when these patients have something like infection, maybe like UTI, maybe hypoxia, but whatever, just know that delirium is uh, short acute onset. So when these patients have this acute onset, they may end up having hallucination, memory impairment, inattention. But the buzzword here is that it's short, is an acute onset. Then how do we manage delirium? We can do non-pharmacological, we can do pharmacological. If they're having those agitation and psychosis, you can give them haloperidol. But you want to also avoid benzodiazepine here, except in withdrawal states. Then dementia is the one that is more progressive, and we are going to see that. But under dementia, we have two types of dementia, okay, which is the cortical dementia and subcortical. So cortical always affect their language, okay, and their memory. It can also affect their vision, visual, visuospatial dysfunction. Okay, so this cortical is usually Alzheimer. But you have your subcortical. Subcortical always has to do with depression and motor. motor problem. One of the other subcortical dementia is like HIV related dementia, but we are not talking about that here. It can also affect apathy, and one of it cause is also vascular dementia. So we're going to look at the differential features of this dementia. So the three major one you must know for the exam is the Alzheimer. Alzheimer is the number one cause of dementia, the most common type. And we know that Alzheimer, there is no cure. There is no cure. Then we have vascular dementia. How do you remember vascular dementia for the exam? It's always after a prolonged, maybe somebody have hypertension, coronary vascular disease, or but it has they are going to include patient have carotid bruit or fundoscopy abnormalities. But in the exam, when patients have a prolonged or have a long history of hypertension, what type of dementia do they have? So this type of dementia now, we say that it is subcortical under subcortical, but Alzheimer is under cortical. Then we also have Lewy body. Lewy body is the one that always has to do with Parkinson, like it has a Parkinson symptoms. But don't forget, not just Parkinson symptom, it also have visual hallucination. Visual. When this patient starts seeing things that are not there, when they start seeing things that are not there, that is visual hallucination. Then another high yield thing in the exam is bulimia nervosa and anorexia nervosa. So what is the difference between the two? The major difference between the two is that because most of them will have the same symptoms. They will have the same symptoms like dental erosion, Russell sign, very important, very high yield. Both of them will have it, but the difference is that bulimia nervosa have a normal BMI. If you look at the question and patient BMI is normal, that is bulimia nervosa, normal BMI. But anorexia nervosa, their BMI is usually low. That is the major difference. And under anorexia nervosa, patients will have lanugo, muscle wasting, electrolyte abnormality. But what you must know is what? They have low BMI. Unlike bulimia nervosa, their BMI is normal. So when you read the question, if they tell you that the BMI is normal, so they are talking about bulimia nervosa. But when they tell you that BMI is low, then they are talking about anorexia nervosa. That is a major thing. Every other finding can almost look like the same. Then the treatment for anorexia nervosa is usually nutritional rehabilitation, psychotherapeutic intervention. So you can start this patient on cognitive behavioral therapy. You can the patient needs to, and another question can be when will you think that this patient condition has approved? When when their period return back to normal and when they have gained more than 10% weight and their vital signs of course is normal. So then another condition is the autism spectrum disorder. Everybody knows that. I don't think it's something we need to spend time. But one thing you need to know about autism spectrum disorder is that these people have a reduced eye contact. So anytime they put these things, symptoms, you need to know reduce eye contact, difficulty with non-verbal clues, the poor social reciprocity. So they may not even, like, maybe when you are making a sign for them, they may not even join you in that play. But one thing to remember here is another things they do is they also the way they play with their toys. They like to line up their toys. They like to stacking. So they like the way they play with their toys too can also make you to know. And it's usually more in male gender and genetic factor. This is a very important too, genetic factor in the male gender more. Okay. Then how do we manage? They can do early intervention. Early intervention is important. It focuses on building communication skill and reducing problematic behavior. Then we talk about ADHD. ADHD, these people are very, very hyperactive, okay, disorganized. All these symptoms here, we know about ADHD, hyperactive impulsivity, okay. So all these symptoms here is what they have, is what they have. And this is the neurobiological basis. I don't know, nobody's gonna be asking you about the, yes, it affects the frontal cortex, the basal ganglia, the reticular activating system, neurotransmitter, but nobody's asking you that. Then we have the treatment for ADHD. We have mentioned it, stimulants and non-stimulants. The stimulant is the amphetamines, methylphenidate. Then monitor the EKG, family history. Okay, family history, that is very high here. Then non-stimulant, guanfacine, clonidine. Then the last situation here is Fragile S. So in Fragile S, we say that this patient will have the, if you remember my song in the video, larger, larger, larger. They can have like a larger forehead, elongated face, larger prominent ear, high arched palate. Okay, so you can continue with the other video and let me know if you have any question.